Blood and blood products in anesthesia, that is the topic. So blood products are any therapeutic substances that are prepared from human blood. That is the definition of blood products. Blood products are any therapeutic substances that are prepared from human blood. And they are classified into cellular components. That is the red cell concentrate, platelet, which are also cells, leukocytes, and platelet apheresis, granulocyte apheresis. These are all the cellular components of the blood which can be separated. And plasma components like FFP, single donor plasma, cryoprecipitate, cryopower plasma, and plasma derivatives. Even though this is part of the plasma component as described in some books, can separate them as derivatives because this albumin, you know how albumin is prepared, Sanjani? You said it is, if you remove all the other things, it becomes albumin. But will you get enough albumin from a single donor?
No, sir. No, sir.
Albumin, actually, what you get in your, have you used albumin in your OT?
Yes, sir.
You have used, especially when
Yes,
you
sir.
do liver transplant cases,
Yes,
you would
sir.
have used, or in
Yes,
cases
sir.
where there is a hypotension, when you want to do volume expansion, you use albumin. After crystalloid, if it is not sustaining, you use albumin. This albumin is produced not from a single person donation. It requires 1,000 to 10,000 donations, and it is prepared in the pharmaceutical industry. That is why the word blood products also can be accepted along with blood components. Okay? So the other
Yes, sir.
coagulation factors, factor 8, fibrinogen, and immunoglobulin, they are all called plasma derivatives, and they are separated, and then other pharmaceutical changes are needed to manufacture them and then market them. Okay, and the component production, how is it done? All donors are tested for hepatitis B, human immunodeficiency virus, and T cell lymphocyte virus, and hepatitis C and syphilis. All these things have to be tested before you accept the donor. And blood components may be derived from whole blood donations or collected by apheresis. What is the difference between whole blood donation and apheresis? What do you do in apheresis?
In apheresis, the donor, from the donor, the blood is collected and components will be separated, like blood components and the plasma we have to separate, and the remaining components will be returned back to the
Return back.
patient.
Okay, so that is
Yes, sir.
immediately done. Whereas in whole blood, you collect the blood, take it to the blood bank, and then do all the separation in the machines available there. Okay. Whereas in the apheresis technique, the patient is allowed or made to recline in the seater, blood is drawn immediately, whatever component is required, that is separated, and whatever balance is not required, it is pumped back or transfused back into the patient. That is the difference between whole blood donation and apheresis. So apheresis is the process by which only the component that is needed is separated and collected, and the rest is returned to the donor. And the component preparation is possible because of these developments. Multiple plastic pack systems have been introduced. Earlier, it was only a single bag. You would have seen in some of the movies when they donate, one tube will go and it will all collect in a single bag. Now we have double bag, triple bag, and even quadruple bag systems are there. So we can collect the blood in different bags, and then refrigerated centrifuge is available. And based on this different specific gravity of the cellular components, they will separate out because of the specific gravity difference. And plasma derivatives are partially purified preparations of human plasma proteins. and produced in a pharmaceutical process. That is why the word blood products also is acceptable, and at least 20,000 individual donations are required for manufacturing your albumin or globulin and other products. And the thawing, that is, once the things are cooled and made into a solidified form by deep freezing, when you want to use that, you have to make it into liquid again. So you heat it up and make them into a liquid, which is the process called thawing. The addition of ethanol or exposure to varying temperatures and pH and ionic strengths, combined with filtration, chromatography, and centrifugation to separate the different groups of proteins, and purification and virus inactivation is performed and supplied as either ready-made solutions which can be transfused or freeze-dried powders. Most of the immunoglobulins which are administered as vaccines or preventive measures, they will all be as a freeze-dried powders. Whereas the albumin solution which you use in your regular OT, they are all supplied as solutions. So this is how the product manufacturing is done. And production of blood component derivatives, this is the first test samples for all these communicable diseases. Then you can do it as a whole blood donation. So you first centrifuge and filter to remove the leukocytes. The white cells are the more reactive agents or cells which have to be removed. And once you remove these leukocytes, it becomes packed red cells, which can be stored at 4 degrees centigrade up to 42 days. And the supernatant plasma will have, which is first called the platelet-rich plasma. Now this platelet-rich plasma, what are all the other indications for use of platelet-rich plasma? Where are we using it? PRP. Is anybody using it in your ortho? Ortho surgeons are very fond of this. In OA cases, have you ever seen them using it intra-articular use of platelet-rich plasma?
No,
And
sir.
in
No, sir.
patients who have hair fall, now
Yes,
they use platelet-rich plasma injection into the scalp to improve the hair growth. So platelet-rich plasma, because it is containing platelet growth factors. So they are just like your stem cell therapy, platelet-rich plasma therapy is being utilized nowadays in inflammatory diseases like osteoarthritis and conditions where alopecia, where all this is being routinely used. So once this platelet-rich plasma is obtained after the first centrifugation, this is again centrifuged to remove the platelets. So, okay, now I think it is stopped. Then you have saline washing of PRCs to remove the residual plasma, and that also you can use when there is a fear of any reaction. So the leukocytes are the culprits, and they can produce antigen-antibody reaction, and transfusion reactions can happen. So they are more specific in removing that leukocyte for producing microaggregate-free blood. The third type of RBCs, packed red blood cells you can get is the irradiated red cells. So gamma radiation is used to destroy the lymphocytes in a unit of packed red blood cells, and that is responsible for the transfusion-related graft versus host diseases. So in PRCs itself, you have the regular PRC, microaggregate free blood, and then irradiated red cells. These are the three types you have. And these are usually used for severely immunocompromised patients with lymphoma or stem cell and marrow transplant. Whenever you do a stem cell transplant or bone marrow transplant surgery, you have to use only irradiated red cells because that will cause a reaction. And in children who are undergoing intrauterine transfusion for any purpose, there also you have to use only irradiated red cells. Then the fourth type is leukocyte depleted red cells. This is a red cell having 99.9% of the white cells removed by freezing or microfiltration. So this reduces the risk of TME or other virus infections like Epstein-Barr and HTLV, and also avoids febrile reaction. So actually you have these four types of PRCs. Regular PRC where some amount of leukocytes may still be present, microaggregate free, irradiated and leukocyte depleted red cells. Then granulocytes. Where do you use leukocytes or granulocytes as a transfusion? Which patients require this? How do you get them? This is another
Severe
component of the
neutropenia. Severe
patients who are
neutropenia.
neutropenic. Very good. Especially
Yes, sir.
cancer patients who have life-threatening infections. Granulocytes are indicated for life-threatening infections in neutropenic cancer patients who are unresponsive to antibiotics. So in them you can give the white cells also. Neutrophils or focytes can be given, and this is prepared by separating blood from blood donated by volunteers who have a high leukocyte count, which can be increased by pre-treatment with corticosteroids or those with chronic granulocytic leukemia. So patients who have granulocytic leukemia, they are very good donors for providing granulocytes for others. And the donation must be cross-matched because they contain large number of red blood cells. So it is a must that you must cross-match to make sure that it is compatible on the same blood group. And they should also be irradiated to remove the lymphocytes which can be causing the febrile reactions. And they are collected either by apheresis or derived from whole blood and stored for 24 hours at 20 to 24 degrees centigrade. So if you want to give granulocytes, it has to be given within 24 hours. Next comes the platelets, which are commonly used in patients who have a deficiency in the number of platelets or functioning of platelet is deranged. Both indications you can give platelets. So platelet transfusion is collected in two ways. One is called the pooled platelets. This is a two-step procedure. First, what you do is you collect 1 unit of platelets produced from one whole blood. So you take the blood from a donor, which will be about 500 ml, and then centrifuge it, and you get the plasma, which is rich in platelet. Then again centrifuge it. Then you get a platelet separately and platelet poor plasma separately. So that platelet can be used. This is the first one. Then 4 to 6 such units from different donors are again done like this, and then all the things are clubbed together. So patients with different blood groups, they are all clubbed together, and this is called the pooled platelet in a single pack. Whereas the second technique is what is called the apheresis platelet, where these are collected from a single donor to reduce the risk of disease transmission. The number of platelets collected with this procedure represents equivalent to 4 to 6 units. So here, because we are returning all the other components back to the patient or the donor, you can collect as much as you want, like equivalent to 4 to 6 random donor platelets. And the shelf life of the platelets, whether it is a pool platelet or if it is a platelet, it's only 3 to 5 days. And it should be stored on an agitator at 22 degrees centigrade. What do you understand this is agitator? Any idea? Jenny? It should not be kept at 22 degrees idle. There is a vibrating plate on which it is kept
Yes, sir.
so that these cells do not break down or lose their uh, shape. So it is kept on a agitator at 22 degrees centigrade at a pH of 6.2 to 7.8. And each bag volume of 250 to 350 ml. And usually it doesn't require a cross match because the platelets have not much of a reactive antigens. So it's not cross match with the recipient, but possible ABO specific, ABO specific should be used wherever possible. If you are able to get the same matching blood group donor for platelets, that's ideal. And the risk of bacterial infection is higher when you use a platelet that is stored for more than 3 days. What are the indications for platelet transfusion? In patients taking platelet inhibitor like clopidogrel, an elderly patient who is on chronic antiplatelet therapy sustains a fractured neck of femur. He has to be operated immediately, otherwise there are likely to be complications. And just because he is on this antiplatelet, he cannot wait. In that situation, you can transfuse platelets and then take up the patient and then resume the drug after you complete the surgery. And invasive interventions, whenever you want to do like a central line or epidural, all of any intervention where there is likelihood of bleeding, then you can prepare the patient by pre-transfusion with platelet. And if the platelet count is less than 50 in those patients, the 50,000, you have to, you can do that. Each adult therapeutic dose is expected to raise the platelet count by approximately 20 into 10 to the power of 9. This is not 109 in most of the adult patients. And the next thing is the fresh frozen plasma, which is mainly used to provide replacement of coagulation factors. And in cases of excessive bleeding, due to those patients with abnormal coagulation, FFP is collected as a supernatant after centrifuging the whole blood. So what you get is the way seen in the earlier slide, how it is being collected, and it is frozen at 70 degrees within 8 hours of collection. This is very, very important. That is why the word fresh has been added to that. And after you collect the blood from the donor, within 8 hours, this freezing has to be done. And it can be stored up to 1 year at minus 30 degrees centigrade. And because you freeze it so much, it will become solidified. It will not remain a liquid. So the packs are brittle. It should be handled with care. And the frozen plasma can be thawed using a dry oven for 10 minutes, or you can microwave it for 2 to 3 minutes, or put it in a water bath for 20 minutes. Then it will become liquefied. Then only you can use it for transfusion. And the third, FFP is best used immediately. So whenever you want to use the fresh FFP, it has to be thawed by these means and then used immediately. Or it may be, supposing you don't require it immediately, but you have made it into a liquid, you can store it at 4 degrees and infuse within 24 hours. So the maximum time after liquefying it is only 24 hours. And at this temperature, it has to be returned to the blood bank storage within 30 minutes of being removed or from a 4 degrees centigrade fridge. And the most important thing, FFP is not indicated purely to increase plasma volume or as a albumin concentration. So this is a very important point that you have to know, that many people mistakenly use FFP as a colloid to improve the circulating volume. That should not be done. And the indications for use of FFP indicated in deficiency of coagulation factors, and also for planned surgery or invasive procedure. The warfarin in presence of active bleeding when vitamin K is inadequate, and in cases of thrombocytopenic purpura, congenital or acquired factors deficiency with no alternate therapy, and trauma patients requiring massive transfusion. Whenever you do massive transfusion, the ratio is 1 part of RBC, 1 part of fresh frozen plasma. And warfarin related intracranial hemorrhages, conditions that cause deficiency of multiple coagulation factors, all these things in liver disease and disseminated intravascular coagulation. And the FFP must be ABO compatible with the recipient's red cells. That is a very important thing. So you must cross match. Contraindications are contraindicated in coagulopathy can be corrected more effectively with a specific therapy. For example, if there is a fibrinogen deficiency, You have to use fibrinogen concentrate rather than fresh FFP as a alternate for that. And contraindicated when blood volume can be adequately replaced with other volume expanders, and it is contraindicated for the reversal of anticoagulation induced by heparin or direct thrombin inhibitor or direct factor 10E inhibitor. So in those conditions, you should not use it. You can rather go in for the other method. And fresh fluorescent plasma to be given in doses calculated to achieve minimum 30% of plasma factor concentration. And it is about 5 to 8 ml per kg of FFP is usually enough. The next component is the cryoprecipitate. When FFP starts to refrigerated temperature of 4 degrees centigrade, then there is a precipitate forms which is rich in high molecular weight proteins, including factor 8, 1 Willebrand factor, and fibrinogen. These are the three important components, and this is known as the cryoprecipitate. So, cryoprecipitate is a combination of factor 8, 1 Willebrand factor, and fibrinogen. So 1 unit of whole blood provides about 15 ml of cryoprecipitate. So if you centrifuge 500 ml of blood, you get only 15 ml of cryoprecipitate, which can be supplied in volumes of 20 to 40 ml. And one pack contains at least 150 to 300 milligram of fibrinogen in that, and about 70 international units of factor 8. Of course, 1 Willebrand factor does not have some measurement. And indications for cryoprecipitate are when fibrinogen concentration is less than 100 milligram per deciliter, the presence of excessive microvascular bleeding, cryo is the choice. Or to correct excessive bleeding, microvascular bleeding in a massively transfused patient when fibrinogen concentration cannot be measured in time. So a trauma patient coming with multiple injuries and bleeding heavily, and you give him what is the definition of passive transfusion, Ranjini?
Transfusion of more than 3 units of Paxil within 1 hour. And
Is that correct? Bindu, you agree with Ranjini's definition of passive
More
transfusion?
than 10 units in 24 hours, sir.
Replacement of blood volume.
More than
Blood volume in
50% of
24
blood
hours.
volume.
That is, blood volume is 5 liters for an adult. So if you replace entire 5 liters in 24 hours, it is called massive transfusion. Otherwise, it also be 500 ml in 10 minutes time. If you are going to rapidly, because in some situations like severe liver injury in a trauma patient who may be bleeding heavily, you may have to transfuse blood much faster to maintain the circulating volume. So it can be defined in so many ways, but replacement of one blood volume within 24 hours is called the massive transfusion. So in such patients, they lose the fibrinogen also. So even if you are not having time to assess the amount of fibrinogen present, you can blindly give cryoprecipitate in them to restore that. And patients with 1 Willebrand diseases and congenital fibrinogen deficiencies, definitely they require cryoprecipitate. And now even the present day, we have able to isolate the fibrinogen itself, and fibrinogen concentrates are available, so that we need not unnecessarily give factor 8 and 1 Willebrand factor. We can directly replace the fibrinogen. So plasma derivatives are human albumin solution. When all the cellular material and coagulation factors are removed, it is mainly the albumin which is left out. It is available as 2 concentration, 4.5% and 20, and a shelf life of 2 years and stored at room temperature. And it is used to restore circulating blood volume and the volume deficiency after removing the ascitic fluid, especially in massive ascites. When you do a paracentesis, they may go into a shock. So it is better to keep the albumin flowing while you are doing the paracentesis to remove the ascites. Then the immunoglobulins are proteins secreted by plasma cells involved in immunological safety. They may be administered to humans or they obtained from human normal immunoglobulins. They are used as long-term replacement therapy for missing or poorly functioning immunoglobulins in patients with antibody deficiency, or it can be used as a short-term therapy also in high doses as an immunomodulatory agent in patients with autoimmune or inflammatory diseases. This is the first indication for human normal immunoglobulin, and it may be given intravascularly for prophylaxis for certain infections like measles. All the vaccines that we give for MMR, the childhood hepatitis, rubella in pregnant women, they are all the human normal immunoglobulin. It may be given intravenously as a replacement therapy for immunodeficiency in various immune-related disorders. Then the second category is hyperimmune immunoglobulins, which are obtained from donors with high titers of specific antibodies, and it can be given intravascularly against hepatitis B, tetanus, rabies, RSV antigen, etc., and the herpes virus also. And immunomodulatory therapy with high dose IV immunoglobulin, IVIG, provides polyclonal immunoglobulin for variety of pathogens, especially the hemolytic disease of the newborn, where the Rh positive, Rh negative incompatibility happens between the mother and the fetus. All of you would have learned about it in your obstetric posting. The mother is Rh negative and the fetus happens to be Rh positive. The first delivery may not have any problem because the mother would not have got sensitized to that, and the first baby may be born normally. But when she conceives again, she already has a antigen against Rh positive blood. So when the second child is also Rh positive, what will happen? The child will have hemolytic reaction inside the uterus, and it will die because of that, and it will bloat up because of the hemolysis that is taking place, and that swollen baby is called
Hydrops fetalis.
hydrops fetalis. Fantastic. So that is the this. So you can immunize the mother against this by giving her the immunoglobulin. So mothers who have Rh negative blood should get immunized if they want to conceive again and have a second baby if they have had a normal child for the first delivery. So NICE has recommended that routine antenatal anti-D prophylaxis should be offered to all non-sensitized pregnant women who have Rh negative at 28 and 34 weeks of pregnancy. Okay. And the coagulation factor concentrates are now available. Recombinant factor 8 and factor 9 are available, and they are used in severe hemophilia. Factor 8 concentrate and factor 9 concentrate can be also plasma derived. So what is the difference between recombinant factor and plasma derived? What is recombinant technology? You heard this word in so many preparations. Recombinant factor 7A, factor 8, factor 9. What do you mean by this recombinant? Okay.
Yeah, used in genetic engineering technologies.
Genetic engineering technology, excellent. So by doing that, you modify the gene and produce them in the factory. Whereas plasma derived is you take it from the donor blood. Okay? So they are also used in hemophilia. Factor 2, factor 7, 9, 10 concentrate are totally called as prothrombin complex concentrate, which are plasma derived. Their main indication is for warfarin overdose where there is a life-threatening bleeding. And recombinant factor 7A, which was introduced about 2 decades ago with a big fanfare, saying that it is the ultimate treatment for any bleeding patient, now lost its importance because of the prohibitive cost. And originally developed for use in hemophilia, patients with inhibitors of factor 8 and 9 or chlortic cascade. works by activating coagulation and platelet adhesion only if tissue factor is exposed. So this is the restriction or limitation of that. It requires the presence of platelets and other coagulation factors to act, this factor 7A, and it's a risk of thrombotic complications are there, and it is extremely expensive. So this is the reason why it has lost its popularity, and very rarely we use it now. So these are all the various components and their indications, their contraindications, etc. Okay? Right. Any